This is NNI Bites Big Learnings, a podcast where fellow healthcare professionals converse about the latest on nutrition science. Join us as Andrew Prentice and Rosan Meyer share their knowledge and updates on the diagnosis and management of faltering growth and catch-up growth in young children.
Welcome to our podcast, NNI Bites Big Learnings. My name is Andrew Prentice, and it's my huge pleasure to welcome Professor Rosan Meyer to today's podcast. Originally from South Africa, Prof. Meyer currently holds research posts in the Department of Nutrition and Dietetics at the University of Winchester in the UK and in the Department of Medicine in Louvain in Belgium. With a multitude of other experience at Imperial College, Great Ormond Street Hospital and St. Thomas's, Rosan is considered one of the world's top experts in pediatric eating difficulties. She runs her own consulting group and has published the Pediatric Dietetic Pocket Guide, which can be accessed online. Rosan, it's a massive pleasure to welcome you to this episode of NNI Bites. Please tell us a little bit more about your everyday practice and perhaps about your pocket guide.
Andrew, it's such a pleasure to be invited, and thank you for that introduction as well. So yes, my day-to-day practice straddles a couple of countries. So I live in France, I work in the UK, work in Belgium, as you already said, and I see a variety of patients, primarily what I would say with gastrointestinal illnesses and, as you already said, feeding difficulties. And I do also support for enteral feeding as well. So I see a lot of children that have faltering growth, for example, vitamin and mineral deficiencies. The pocket guide that you've highlighted is actually one that was driven by a bite-sized little book that any healthcare professional can really put in their pocket. So it's really small, and then they can really look at any diagnoses or any condition and find in bite sizes just nutritional management, nutritional tips. And it starts with anthropometrics, biochemistry, clinical assessment, dietary assessment, and then goes through management for most of the diagnoses. So yeah, we hope it's really practical and really something that people can use on a ward when they're busy with patients as well.
Great, and anybody will find that easily with a Google search. So
Very
today
easily.
Today we're discussing your paper on an update on the diagnosis and management of faltering growth and catch-up growth in young children. And this appeared in a recent issue of Analyse Nestlé. It was part of a series on the importance of assessing growth in infants and young children. And we're hoping that many of our listeners will be healthcare professionals who, in their day-to-day contacts with families and children, will be able to make a real difference. So let's start perhaps by a little bit of terminology. Is faltering growth the new term for failure to thrive? And if so, why the change?
That's such a good question, Andrew. I think the answer is yes. We prefer faltering growth to be used instead of failure to thrive. And there's a very simple reason for that. So we think about the term failure to thrive. It started to be used in the 20th century and was really used for orphan children to describe poor growth. And it was linked to limited maternal support as well. But, that's not a stigma we want to put to the children that don't grow very well. So we do not want them to think if they've got a diagnosis of failure to thrive, that there's a failure of parenting. So therefore, there has been this shift from failure to thrive to faltering growth, which does not imply that there's been a failure, but rather just describing more that what's been happening.
That's so important, isn't it?
Absolutely.
Great. Now, let's next move to how we would define this faltering growth. You have a box in your paper that includes a bewildering list of possible definitions. And really, I think the point of this whole episode, this whole collection in Analyse, was to try and simplify things down, take away some of the complexity and mystique. So could you summarize the key elements of defining faltering growth in the best way you would do so, and give us your recommendation as to what HCP should use?
Absolutely. Andrew, first of all, I didn't want to overwhelm anybody with such a box, but I did want to give some historical context, which started with some definitions from 1956. I think the first aspect that I want to make clear is, although I will provide very clear guidance on a definition for faltering growth, I want to also say that there are countries that have very specific guidelines to what healthcare professionals should be using. For example, in the UK, we have very clear guidance on what faltering growth is. So I don't want to take away what should be used within a country. But I think...
Okay, that's news to me, right?
Yeah, so I think what is also important is to recognize that as a result of poor definition and everybody using something different, in particular also from a research perspective, we sit with poor data because there's no unified definition. So what we've tried last year is come up with a consensus, and the consensus is really based on the WHO Z scores, because those are universally accepted tools that we have. And I can't think of a country that doesn't use WHO Z scores or growth charts at least. And we have looked at what current definitions are, meaning looking at what the trajectories are in terms of growth charts, and found that there's data to support a drop over of one Z score in weight for age over 1 month, excluding the first 2 weeks of life, so where you often get that drop in weight.
Yeah.
And we've used that as a good guidance for healthcare professional to say, if you have this drop of one Z score of weight for age, in the context that I've just mentioned, where you ruled out that's not related to acute diarrhea or vomiting, for example, because that's of course not faltering growth, then that would be absolutely worth investigating whether a child has got faltering growth. And so that is what we suggest as a universal definition for faltering growth. And we suggest also that this is used for research, because you and me both work in research, and it's so frustrating when somebody says to me, give me the data on what is the prevalence. And the problem that I've got is because everybody's used a different definition, it's made it very difficult. So we're hoping by putting this one Z score drop in weight for age out as a universal definition, that we can unify not only research, but give healthcare professional the guidance to say, this is what you use as a baseline, and then we move into your clinical assessment for the patient.
Yeah. So as you also pointed out in your paper, there are wide discrepancies around the world. In the rural villages where I work here in the Gambia, every child will show faltering growth by losing more than one Z score as they approach their second birthday. So there's lots of systemic causes, poverty and everything, but let's stick to the clinical here and look at the causes of faltering growth, perhaps in an individual child. And you've outlined 3 of those causes. Can you just run through those for us?
No, thank you, Andrew, for that. And before I answer, I want to say I so understand the different contexts of where you come from and where I come from. So the 3 important primary causes you can put into these categories. First is the increased requirements, the increased losses, and reduced intake. So let me give you a very practical example to make it real for all of our listeners. So if we think about increased requirements, many of our clinical diagnoses, if we're thinking about congenital heart disease, for example, you have increased requirements, can fit into that category that can drive faltering growth. If we're thinking about increased losses, we can have diarrhea, for example, and you might see that also a lot of times. I see enteropathy, so you have increased losses there. And then we have reduced intake. Now, reduced intake is a very important one for me. In where I come from, reduced intake often is driven by a clinical diagnosis that leads to feeding difficulties or pain with intake. But what is important is that reduced intake can also be related to actually not having the resources, so food insecurity. So what we really want is people to think in these 3 broad categories. And wherever you are in the world, whether faltering growth is driven by food insecurity, not having enough, you can think about that within those three categories. Or where I am from, where the primary reason for faltering growth are the clinical diagnosis, you can think about the increased requirements. It's really important to really deconstruct faltering growth and think, what am I dealing with? Because that leads to then your clinical management and addressing that better.
And how do they start that task of diagnosis, start to understand the underlying causes in preparation, as you've just said, for making a management plan?
Absolutely. And I think here, it's not something that we are already doing, but I think it's really important to formalize it. I think the key is first the history. That's not just the medical history, but the family history, and thinking about the environment that this child is growing up. That might be different, Andrew, for example, in your environment than in my environment. That includes the carers. Once we've done that history taking, that detailed history taking, one needs to then move to the physical examination. And that physical examination, of course, you think about not only listening to the heart, feeling the abdomen, but you also visualize and look at the child, and you think about bowel motions, looking at the texture, the frequency, vomiting, all of those factors, because your physical examination and your history also leads to, do you need further investigations? As a dietitian, that may often be that I look at a child clinically, I've done my history taking, and I think, gosh, this child is at risk of some of the vitamin or mineral deficiencies, and I might want to do some iron test assessment, or I want to think about vitamin A, vitamin D. Then critical is, what is the child currently consuming? Because if we think about our three principles, it might be just a principle of reduced intake. Or it may be that the child has a reduced intake because you identify with the current intake that they're actually refusing to eat. So food refusal is at the heart of it. Or you might find with current feeding that is eating a lot, and you can't find a reason for reduced intake to be a cause. And then you kind of think, is it increased losses or increased requirements? So I think if we think history taking, very detailed history taking, physical examination, current dietary intake, that guides you to, you make your preliminary diagnosis or you think about further diagnostic tests.
And I guess also, I don't want to take you down this because we haven't got time, but looking at the parents is sometimes important as well.
Yeah, as I said in your history taking, the carer, whether that is, who is the carer there? Is it the grandmother? Is the parents? Is it the nursery? And what is the relationship? The carer-child relationship is really important as well.
Right. I think we've taken that in some detail. Let's very quickly, if we may, just start thinking about the energy and protein needs then, and then we'll come on to vitamins and minerals.
Yeah. So, Andrew, we have already in 2007 quite good guidelines with a joint publication from the WHO, FAO on amino acid requirements. And within that document, which we really use as baseline, the basic principle is to have good catch-up, which you want to have where you have a lean muscle mass or lean body mass catch-up of around 70, if we put it like that, and around 30% fat mass. You don't just give energy without protein. So what we're aiming for is between, if I round it up, between 9 to 12% of energy as protein, and you have it balanced. If you give it imbalanced, what I mean by that, you just give energy, so just carbohydrate and fat, for example, what you may see is that you may have weight gain, but that weight gain is not necessarily the right weight gain. So you do not have necessarily the right ratio between fat and lean body mass. So that's a really important message, that you want to give both energy and protein at the right kind of ratio.
Yeah. And I guess in vitamins and minerals, it's pretty obvious, really, that you've got to make sure that the intakes are more than satisfactory.
Absolutely. So I think there's two limbs. It's thinking about vitamins and minerals as a cofactor to make sure the energy and protein is used in the right way. And we think, you and me both know that zinc is critical. And if you've got losses, to make sure that you don't have excessive sodium losses. So those are really important. But also we need to think here in an environment where you might have real deficiencies. So I've often been exposed to a child where we're pouring in the calories, but actually we never tested for zinc deficiency. And actually, once we started to correct for that, and so a child had a deficiency, so it's not only giving the right cofactors for the energy and protein to be used, but it's taking into account if you have a deficiency of iron, of zinc, of many of the micronutrients that are essential for catch-up growth, then you do need to increase that as well.
Yeah, absolutely. Now, we're coming towards the end, but I did want to get you to share a couple of other things. So the first of those is about breastfeeding.
Yeah. So
you and I are, of course, sorry to interrupt you. You and I, of course, are great devotees of breastfeeding. But tell us your views on breastfeeding. And sometimes this can be a difficult transition away from breastfeeding towards the mixed diet.
Yeah, Andrew, I mean, we both can't reinforce the importance also in faltering growth to promote breastfeeding. And so that is really important, that when we have a child that is breastfed, has got faltering growth, that we get our support of people that know about breastfeeding to assess the efficacy and what's happening from that perspective. But then there is, as you said, this transitioning to mixed feeding, and that is often a very individualized journey that you and me as healthcare professionals also need to direct, because it depends on, you know, the child's underlying diagnosis, the clinical history, and all of those type of factors. So I think one fits all is not the right approach when it comes to the transitioning. So whilst we always promote the breastfeeding, we need to also talk about, when we transition to complementary foods in the context of faltering growth, that we first of all think, is it appropriate for the child? Has the child got the oral motor skills that might change and be different with different children? And then the next aspect is we need to think about culturally accepted foods, and foods that are available, that are cost effective, can be obtained locally, and also what the nutritional content of it is. For me as a dietitian, I'd be then thinking, what is protein and energy rich at the same time, whilst also contributing to micronutrients. I think a lot about, you know, in the UK context, we often use nut butters, and I know in many countries, you know, nut butter can be very useful. So I think this transitioning journey is promoting breastfeeding, thinking about the individual child and the parents involved, and making the right decision in terms of transitioning, taking that child's own journey into account and providing appropriate advice within the environment. But I think complementary feeding at the right age is really useful for catch-up growth. We get a high nutrient density and can often help take the pressure off parents by getting the right complementary foods in to promote catch-up growth.
Great. We've run out of time, Rosan, but a quick last word on how our listeners should monitor the child's future progress.
Absolutely. Andrew, that's key. You cannot implement a management program without monitoring. So when you see a child, I think the question is, how severe is the faltering growth? And based on the severity and your plan you put in place, you make decisions, and there's guidelines within the paper how to calculate at which intervals you need to see. But please, most important message that comes across here is, do not send a child back home without having a plan of when to monitor, because we do not want excessive weight gain beyond where you want them to catch up as well, as that also has negative consequences.
Thank you for listening to our podcast, and we hope that you'll subscribe through the NNI 365 to future offerings from NNI Bites Big Learnings.
And that concludes today's episode. Thank you for joining us with Andrew Prentice and Rosan Meyer as we talked about updates on the diagnosis and management of faltering growth and catch-up growth in young children. We hope you enjoyed and learned from this quick discussion, fellow experts. Till the next episode.